Hello, it is a pleasure for me to introduce you to the telemedicine panel. We're talking about the future of telehealth. And my name is Doug Sumuraga. I am the CEO of Untitled Health. And with me today is Dr. Brittany Busse, MD, President and co-founder of Untitled Health, Harjot Singh, and Chris Pavlatos, founder of Patient MD. And what I'd like to do is for each of them to introduce themselves, starting with Brittany, Chris, and Harjot.
Hi, everybody. Welcome to our chat today on the future of telehealth. I'm Dr. Brittany Busse. Like Doug said, I am the president and chief medical officer and co-founder of Untitled Health. I've been in the telehealth space for about 6 years now, mostly consulting with companies in occupational health and policies and procedures surrounding telehealth in that space.
Thank you.
Hi, my name is Dr. Chris Pavlatos. I am a board-certified internist and orthopedic surgeon, MBA from Kellogg, and CEO and founder of Patient MD.
Thank you, Chris. Harjot?
Hi, this is Harjot Singh. I'm a physician turned healthcare leader turned advisor and coach now. I'm chief of service of Kingsview Behavioral Health in California. And I have been doing telehealth since January 2006. So at this point, over 30,000 hours of work and counting. So I'm also faculty at American College of Healthcare Executives. So my work is, informed by all three perspectives, and that's what I bring.
Fantastic, Harjot. So today we've got some questions, and I hope that we will be as candid as possible with our experiences being brought to the table, different perspectives that we have here, but all with a lot of experience with telemedicine and telehealth. So the first question I'd like to pose on the panel and get a couple of different perspectives. Telehealth is a tool. We all know it's a tool. From your clinical perspective as physicians, what would make the telehealth experience the preferred doctor-patient visit before choosing an in-person visit? So who would like to go first with that? Chris?
Sure. From my perspective, I think what's really important is that we realize that probably close to 65 to 70% of patient visits do not require to have the ability to have to examine a patient, that many things can be done virtually. So I think what's really important for doctors to make it better is to have a list of diagnoses that they feel can be treated through virtual visits. I think having that first, rather than people all of a sudden scheduling telemedicine visits that are just not going to be able to be properly managed virtually, that will require an inpatient visit. So I think having a list of diagnoses is really important. Second of all, I think it's important to have access to patient data. So as we begin to see more interoperability in the market and patient data is more available, not just to us as physicians, but it's available to the patient, who can begin gathering that data from multiple sources and be able to share that with their doctors through use of telemedicine means or any digital means, is extremely important, because then we're able to make better decisions on the care of that patient. Other options, obviously, healthcare is a business and doctors have to run a business. So making sure that reimbursement is at least close to inpatient or in-person visits, I think is important. And we certainly saw that during the pandemic, and hopefully that still holds, because I think that creates the incentive for doctors to still want to be able to offer telemedicine visits. The other thing that's going to dictate doctors providing this is the demand side. We're moving into a consumer-driven marketplace, and patients are demanding convenience, and they want the convenience that they see in other industries, from the banking industry, from the entertainment industry, the airline industry. They want a similar situation like that. So from that perspective, I think those are some of the key features that I think would be beneficial to promote telemedicine.
Brittany, what are your thoughts there?
So I agree with most of those points. I think, coming from the occupational health perspective, we would say, even 85 to 90% of those visits could be handled digitally, because the majority of those visits are musculoskeletal in nature, sprains, strains, overexertion type injuries, things that people get from repetitive motion. And, it's important for people to know that we are still doing an exam, and there's a lot that can be seen and done over telehealth. We are able to really inspect the area. We can have the patient do range of motion in front of us on the camera. So it's really important to say that we are doing it with video. And so you're getting a lot more from that interaction. Just because you're not putting hands physically on the injured body part, you really are still able to get a lot from the exam in those situations. For general health type situations, I've spoken to physicians. They are really keen on having the ability to have more digital devices that are in the patient's homes. So vital signs are really important for chronic care management. So getting those devices out to patients, making them simple to use, simple to connect, simple to get the data out to the doctors. And my doctor was listening to my chest the other day, and she said, I'll do telehealth when I can have a stethoscope that works as well as this one. So she couldn't really see herself doing telehealth at the time. But I have yet to show her the one that I have, which I think does work just as well. It's like I said, getting that equipment to the patient in question prior to the telehealth visit, or making that equipment so affordable that every patient could have a doctor's bag in their home. I think finally would be important to talk about the fact that in many states and also federally, there are regulations preventing telehealth visits from being a first-time visit. So to establish a doctor-patient relationship, for many situations, you do have to have an in-person visit. That changed a lot during COVID, but there are situations where states and federally, they still require patients to be seen in person prior to having any telehealth administered. So all of those things would be important to change before we can really have a digital first experience.
Great thoughts, Brittany. And Harjot, I'm sure you've come across and have comments on what both Brittany and Chris have shared here in the telehealth world. Now, you as you mentioned earlier, have been doing and clocked in how many hours of telehealth visits?
Over 30,000. We stopped counting after that.
Okay, right. You stopped counting. Exactly. So
Yes.
you've got firsthand experience, and you've seen what works, what doesn't work. Share with us your experiences there on this telehealth as a tool.
Both Chris and Brittany said something so eloquently, which is when we start talking about preference, sometimes the focus is on the patient preference, and sometimes the patient is on the doctor's preference. However, the reality is we have to integrate the both. And second thing is the integration has to happen with new ideas. So we can't be practicing almost like 19th century medicine. I'm sitting under the apple tree and seeing patients. It has to involve, like Brittany said, something better than a stethoscope. We have off-the-shelf technology which can be integrated now. So that will really eliminate 65 to 90% of office visits, which actually should not be done. They have no point or a purpose. But sometimes we are forced to do, and I have no shame in saying, because of billing purposes. Because the state law says you can't bill if you didn't see the diocese, if you didn't see the patient. Now, of course, COVID came and uprooted all those things. Imagine how fast the transformation happened. I remember in summer of 2012, 9 years ago, there was American Telemedicine Association's meeting in Washington, D.C. We had congressmen from both sides, and we were saying, give us national licensing.
Right.
Nothing happened. Nothing. And COVID comes and boom, it was never an issue. So that means that this kind of just haphazardly put change can be very, very difficult. But if you try to organize the material, if you try to see it in your head, we're doing it for Innovator MD. So we are focusing on MDs who are thinking of telehealth. So my message to them is, you have to take the lead in this thing. You cannot just sit back and say, I'll just go and sit and use the stethoscope that's given to me. You have to take active role in this process. There are going to be 4 layers of issues and problems. The very first layer always is the legal issues. We can't get around that. We just talked about a legal issue, which is the licensing issue. Mm-hmm. Second is the financial factors. We can't, and Chris was talking about financial factors. We can't get around that thing. It's very, very difficult. So we have to make it work. Now think about the innovation. In psychiatry, for the last 10 years, we have integrated health in which the psychiatrist doesn't see the patient, but guides the other physicians in managing their patients. Research shows it's good for the patient, it's good for the doctor, and it's good for the consultant. We haven't figured out a way to pay the psychiatrist till now. So financial fact, and the program can't take off in the majority of the country, even though the program is known to work. It is an innovation. Integrated behavioral health is an innovation, and we can't apply it. National Institute of Health has even stopped measuring if it works. They're just seeing how are the better applications of this going to be. We can't use it. So legal factors, financial factors, and then come the technical factors, right, which means the remote teams can get kind of very much lost in technical issues sometimes. I remember using T1 lines when we were there. We were using the hardware and software were integrated, and we couldn't do what we're doing right now. The equipment that used to cost $30,000, now I can set it up for $800, $400, even if we start pushing it. So technical factors, and we know that remote teams can spend, a remote team leader can end up spending up to 8 hours a week just doing email and texting and messaging and stuff like that. So technical factors have to be taken into account as well. However, if the program is going to sustain itself, the program has to take care of human factors. So the human factor, which is the patient on that end and the doctor on this end, they all have to be taken care of. I'm a big fan of our human force, and we call them our telemedicine champions. So the team that's on the other end, which is on the distal end, needs to have a champion. Even though people have written guidelines about it, and they try to call them coordinators. No, they are the champions. I have seen the difference where a champion made the program a success, and where they had a turnover, we couldn't find a champion, and the program failed. So the legal stuff was in place, technical stuff was fine, financial stuff was running, but because we did not have a champion on the other end, the program fell.
Yeah, so the value of people, Harjot, right, is so important. And on that note that you're making, I want to jump to the next question because it has that hands-on importance. And that's this. Do you have thoughts on advancing a hybrid model of care with a combination of in-person and virtual care?
Yes, I can start, I guess, with that one too.
Sure.
Anyone can start, but we at Vital Health definitely believe that it's a digital first model, not a digital only model. Like we all know, there will still be situations where follow-up will have to be done in person for primary care issues, for orthopedic issues. There will be times when someone from the team should lay hands on a person. So the way that we've done that, very frequently in occupational health is by partnering with in-person providers. So usually therapists, physical therapists, occupational therapists who put their hands on the person and let you know really what's going on with them musculoskeletally, which I felt was really important part of what we were doing in occupational health, because what you see in this area is that most providers were not experienced or trained in doing a good musculoskeletal exam. They aren't orthopedic surgeons like Chris, they're just maybe internists, or they are, interns who went to work at urgent cares or concentras who really have no idea what they're doing when it comes to an exam. So I think it's really important to realize that as much as you can do a really good exam remotely, and that 85% of the diagnosis is going to come from listening to the patient, from taking a good history from that patient. There are times when you're going to have to physically put hands on the patient or listen to the patient's heart and lung sounds in person, just as a follow-up, but do some of the interim follow-ups remotely. So we really want to champion that type of model where we use our time resources and our physical location resources well between all physicians in a group, where we're not just stuck in a clinic, or you're not just working from home, but you have the capability to use both sides of that facility.
Thank you for that, Brittany. Chris?
Yeah, the hybrid model I think is critical moving forward. One, patients are going to demand it. Two, it's a money and time saving process. So if you're in a value-based healthcare system and you're taking potentially full risk capitation, I think it's important to be able to have that hybrid model, because you certainly save a lot of time and money by going through having telemedicine visits. So from that perspective, I think it's going to be really important. And the other thing is people want to stay healthy and don't want to get sick. And we're starting to see more and more the adoption of smart watches, other home devices, sensors at home that produce tremendous amount of data that in the technical world referred to as the IoT data, Internet of Things data. And that data is extremely important. In fact, there was a nice review done by Deloitte, who projects that within several years, IoT data, that data coming from home, is actually going to be more important than data that you get from a hospital or a doctor's office, which tends to be episodic data. And here we're getting continuous data from these monitors, where we can then use technology and artificial intelligence to be able to detect if there's going to be a problem and be able to manage patients from home. And patients want that. They want to be able to be managed from home. If there's any problem, catch it early so patients don't have to go to a hospital or to an emergency room, where we all know that once you're in the hospital, bad things can happen. So you don't want to go there. So I think from that perspective, I think you need that hybrid model. And I think physicians that do offer the hybrid model are the ones that are going to flourish in their practices, because it's going to be a demand that patients are going to want. Things that we're still going to need to see, obviously, the prices of some of these devices going down. We're going to need to see a lot more broadband in the rural areas where access is somewhat limited. Growth in the 5G network, I think, also would be advantageous. I think all those factors coming together, I think, make it a perfect timing for a hybrid model for physicians to adopt.
Thank you, Chris. Harjot, you have a thought?
Well, I totally agree with everything, mainly because what I have seen so far is that at this point, even in our wildest dreams, we can't think of what's going to happen, what we can hope, what we can do. It's kind of like a wild, wild west out there.
It is, isn't it?
But yes, it is. And
it's a very fragmented market. Still, it's very fragmented.
Yes, very, very fragmented.
Tremendous opportunities right now.
We have tried so many video conferencing platforms. It's like unbelievable. And what I have found is that if you set aside time to talk to people who have boots on the ground, they come up with ideas, workarounds, or you can call it innovation, that I can't even think. I can't come up with it, because they know what's happening on the ground. They have done things. They know their local resources. Things happen if you are open-minded. So instead of having that top-down model that we know the answers and then we're going to go and tell these people what is going to be working, no, you listen to them and you figure out they know more than you. In fact, patients know more than us about what's going to work for them and what's not going to work for them. So imagine, let's think of a hybrid model. Now think of how wild this model is. But some of this has already been applied when the doctor has been traveling to patients' homes. So high-risk patients who have volume of admissions each year. So let's say a patient who gets hospitalized more than 3 times a month. I'm just making it up. They're costing so much. And we know at this point, if you figure out a way for them, for the doctor to go to their home, and the volume of visits goes down, the patients are healthier, they live longer. However, now think about, how about the people who are on the cusp and did not even qualify for this level of services? How about if we have people who are not physicians, but who are out in the field, and they go and they can put their hands on the patient, like what Brittany was saying. And you have 4 people out in the field. One is setting up the patient for the doctor to see. Second is where the doctor is actually seeing the patient. Third is who's wrapping up with the patient. And the fourth one is traveling out in the field. And
Right.
how many patients are still in their homes? We're using all the devices, which at this point are really off the shelf. We haven't even used off the shelf stuff that's out there. Doctor is still in their office, and such a simple innovation. You are of course, there is so much cost savings. The patients don't have to travel. The time is being saved, and patient acceptance is high. There is no-show rate in this model, and the doctor satisfaction rate is very high, because this is a true hybrid model, in a way that the patient is being seen in person while remote at the same time. So it is a wild, wild west out there. So this is not the only one. And this idea was actually brought up by one of our case managers.
Yeah.
She brought it up, and I said, wow, look at that.
Absolutely.
And the other thing, Harjot, it's not just improving what's best for the patient and the doctor. Let's look at it even from the employer side. When you can have patients that don't have to take a day off from work
Oh, yeah.
go see a
that's right.
doctor, the loss in productivity at an
Yes.
employer's
Yes.
has a significant economic effect on our economy. So having the convenience of maybe over lunch hour or taking an hour break to have a telemedicine visit with your doctor and not having to leave work and still be able to be there, and they don't miss revenue. They don't have to use a sick day or a vacation day, what has you, is a huge benefit to
That's
not just
right.
the patients and us, but the employer.
The workers' compensation industry is $100 billion industry, a lot of which is, how do we keep the employee healthy? Let's look at preventive or holistic type of care, which brings us to the third question. So I appreciate everything that you guys have brought up there, Harjot. And when we look at holistic care, how do we improve upon current telehealth models to promote a more holistic patient care model? Patients are, and do we even want to use that term, right? It could be employees. It can be, they're not patients yet, right? The idea is that they want to remain healthy. So how do they become, whether they're an athlete? I was just speaking with a group that focuses on athletes. The Olympics is going on right now, right? They want to stay in the game. If you're an employee, employers and yourself as an employee wants to stay healthy and working. And more people are taking responsibility for their own health. So how do we promote a more holistic patient care model? And how does this benefit doctors as well as their patients?
The area where I think it's going to be extremely advantageous is in the ability to care coordinate for the future of virtual care, because one of the things that you see many people go to the Mayo Clinic is because they get a team experience. It's a team-based approach to managing a patient's care, where you go there, you get all the visits, you get all the tests, you see all the different doctors, and they collectively come together and tell you, okay, this is what we're going to do and how to manage you. So imagine being able for us to manage patients with chronic disease, who we know cause 75% of healthcare expenditures. Over 50% of the population has at least one chronic disease. That if you have a patient with diabetes, hypertension, cardiac issues, COPD, to be able to bring in the primary care specialist as a moderator, you have the cardiologist, you have the pulmonologist and the endocrinologist there. You're doing a Zoom-like meeting with the patient and their family there, saying, okay, these are the medicines you're taking. We're going to eliminate this. We're going to add this to your regimen in the management of your care. And you get a common agreement from all the different parties in the management of your care. How often do we see that now? Many times we write a prescription and the other doctor doesn't know what prescription was written in many cases. And you write a prescription and that may interfere with the drug that the patient's currently taking. So having the ability to create that patient experience where they feel comfortable, where all their doctors having a Zoom meeting like this, where you can see all the doctors, ask them all the questions, and they're telling you this is how we're going to manage your care. And as we move more and more into a value-based healthcare system, and especially in full risk capitation, I think having this team approach where you could do it maybe once or twice a year with the patient, depending on the severity of their medical conditions, I think is going to be a huge benefit, not just to patients, but to doctors, because we feel like we're providing the best quality of care we can to our patients. And obviously that's the reason why we went into medicine. And being able to do that and provide that to a patient, I think can be extremely rewarding.
So team collaboration and using technology to advance that collaboration in a practical way is what I heard, Chris, maybe once or twice a year where you can bring all the team members together, because you can't really do that on a regular basis, right?
No,
so
that's right.
But setting up a plan, very interesting. Brittany, do you have thoughts on this?
Yeah, I mean, I definitely agree with Chris in that sense that, you know, collaboration is extremely important. You need to have all of your care providers on the same page, and that's really helpful for the individual as well. But I guess stepping it back, even from chronic care patients to people, like you said, who are otherwise healthy. So for employers who have a large healthy population, who potentially just want to prevent injuries. They want to be looking for things in their employees, screening for mental health issues, screening for stress, screening for burnout. You can really incorporate a lot of those tools into your practice that people can use on a daily basis or a weekly basis just to keep track of their own health goals. And if they do have something coming up, making it really easy for people to get the education that they need, make it easy for them maybe to get laboratory exams even before seeing a doctor if they just have a concern, and that, you know, can refer them to a doctor in the case that something comes back negative. We see people taking this into their own hands already all the time. There are companies that are really well out there providing people at-home testing for all kinds of things like gluten intolerance, other food allergies, and people are out there and they're taking these tests and they're not necessarily getting any kind of follow-up on them. So incorporating testing into your holistic treatment plan, and also incorporating other types of providers into that program. So allowing people access to health coaches, access to nutritionists, access to behavioral health specialists, all of the people that they may want to talk to, you know, including for, like, say, skin concerns. A lot of people maybe are better served by an esthetician than a dermatologist, and they just don't know that. Or they're better served by a massage therapist than a pain specialist, and they just don't know that. So providing them the resources to tailor their care is something that patients and people are asking for. People want body autonomy. People want to feel in charge of their own health. And, you know, Harjot had said this earlier too, is that what we're seeing is that, you know, people will want a physician for guidance. And it won't be that top-down approach anymore, where the physician is telling them what to do and they're just going to go ahead and do it. We're going to have to incorporate other kinds of care providers. We're going to have to educate ourselves in addition to the patients, and we're going to have to do a better job listening. And I think telehealth can help us with all of those things.
Thank you, Brittany. And great thoughts. And Harjot, on that thought, because you're much about training and QA and getting it out there, share with us your thoughts on that perspective.
Well, this is where they both said it right. One of my great culture teachers was a neurosurgeon in India. I was moonlighting in an emergency room. He taught me in medical school, but he later on moved to this hospital. If we had a patient and if he had 5 minutes, he would walk out of the ER and he would find the family. But because in that place, you know, there would be people from the neighborhood, people from the village, sometimes the village chief is there. He would gather everyone. And no matter what, he would answer everybody's questions because
No,
he knew.
no,
Yes.
no concerns then, huh?
Well, here's the thing. He said, look, they all know each other.
Right.
And it's almost like insulting somebody because then that person who feels like who was not heard is going to create problems to the doctor and patient care. Whereas if you calm everybody down just by acknowledging them, you would comfort them. And what Chris said, it's like I used to consult with a group home in Mariposa County, California. Very, very nice place to work. But it was never the patient alone. It was always a therapist. It was the non-therapy staff in the group home and the family members. And with telemedicine, we were able to get everybody in. And even in 5 minutes, you could address their concerns. The treatment went smoothly. Because you see, in the mind of the patient who depends on the family, there are so many pressures they go through. Oh, that doctor doesn't care. Oh, that doctor gave you a medicine that killed my neighbor. And now the patient is refusing the medication. And you come back 2 weeks later and the patient has not even taken the medication. Or the staff is calling you, the patient isn't taking the medication. But if you listen to them, you talk to them, telemedicine is like beautiful for this. And now it's so cheap, there's no reason not to do this. So what can be more holistic than, putting all the human beings together, listening to their concerns.
Giving them real news and not the opposite that we seem to be talking about all the time here today in the media. Give them real news, not the opposite.
That's right. And one of the things that, I emphasize more about primary care and specialists coming together. But as Brittany said, and you said, Harjot, it's bringing other providers also in on the care. Because one of the key issues for managing a patient's well-being and their health is looking at the social determinants of health. And we know that requires other providers to be involved in the caregiving team. So being able to bring in the clinical providers and social workers, dietitians, behavioral health, and all the other people together to do a comprehensive management of patient care, I think is the ultimate that we should all strive to achieve.
And even when we talk about training staff, these are live trainings with the patient right there that happen. You want to educate your staff, you educate the family, staff, patient, all at the same time. And over time, the staff gets the hint that you're going to say the same thing again. And so they get what you're going to do, what you expect them to do. The quality of care goes up that way. And the staff satisfaction and patient satisfaction too. I'm sorry.
So which kind of
sorry, Doug, I would just add one thing, that we saw a lot, and that was in the compassionate care model. And it always had to start with agency. If you take away somebody's agency, then you are going to fail in treating them. And that's going to happen every single time. And if you don't advocate for them and you don't listen to what's going on with them, you're not going to succeed in having a good patient physician relationship with that person. So I think, like everyone's saying, telehealth is a great place for both agency and advocacy because you're allowing so many people to be heard. And when someone feels really heard, then they're going to want to participate in the treatment plan or the preventative health plan or whatever else you feel like is going to be helpful for them in that situation.
Thank you for that. So we've been focusing on the patients. Let's go to the other side of what telehealth does in impacting healthcare for providers. Can telehealth help reverse the trend of clinician burnout? Brittany.
Yeah, so this is something that I am particularly passionate about because as a physician, I had gone through several stages of burnout, several instances of burnout clinically. And when I had heard about telehealth, I thought, oh my gosh, this is the answer to all of my pain points. I had a friend who had been working remotely in consulting and government work for a long time. And I would always just think in my head, if I could do that, if I didn't have to show up to the clinic every day, I would have such a better quality of life. And like I said, it goes back to agency again. What does the physician want to do? What is going to be beneficial for that physician in caring for patients and really fulfilling their purpose and utilizing their unique skills? And how do they find the patients that they're going to connect with? Sometimes you're in a limited geographic area and you're trying to provide care for people you're just not connecting with. And maybe you have a passion for lifestyle medicine or functional medicine, and at your clinic, you're doing mostly chronic care management and nobody wants to change their diet. They just want you to give them more pills, and you're burning out because you're not really living up to what you feel like is your purpose in life. Well, the great thing about telehealth is you can expand your geographic presence. You can start marketing yourself and you can find the people that you're going to connect with who you're really going to help provide services to. And you can do that on your own time, at your own schedule. And you can use other digital tools to supplement your income so you can actually see less patients and have more of an impact. So I think that telehealth is providing an immense opportunity to help physicians really balance in their work-life schedule, again, by bringing them closer to patients, by helping them connect with other care providers so they're not taking the burden of care all upon themselves, that they can act in a capacity of guiding healing and really quarterbacking that person's healing process and coaching them through their healing journey rather than taking the full responsibility for patient healing on themselves, which is really the old paradigm of care, something we need to start moving away from.
Beautiful. Chris, I'm sure you have thoughts on this as well.
Yeah, certainly burnout is a big problem right now that we're seeing. We're seeing a fairly high suicide rate in doctors. Some reports say as much as one doctor per day has committed suicide in the U.S., which is obviously very tragic. From a burnout perspective, doctors want to be able to do their work, but then want to be able to go home and spend time with their families. One area, you never want to bring your work at home, but if you can get out of the office a little earlier, spend some time with your family, and then finish some of your visits at home via telemedicine, I think that could create a little bit better balance to do that on an occasional basis so you're not stuck in the office finishing all your work and being away from your family. And then if you have young kids, your kids are going to go to sleep by the time you get home. You don't spend time to see them. So having the ability to maybe take some of your visits and put them towards the end of the day and leave the office and go back home, spend time with your family, have dinner, and then finish up your office at home virtually, I think could be another attractive feature for you to do on an occasional basis to help address some of the burnout issues.
And I guess I would just add to that, as a person who's been doing kind of full-time telehealth for a while, is that I think it is good to have a space that is dedicated to your work. But honestly, I embrace the opportunities to be more human in my interactions with patients. I mean, we started seeing this a lot when people did Zoom calls. I mean, you have a kid running through the background or my dog's in the background. Honestly, patients, they love it. And they see me as a human being, and they are a lot more likely to open up to me. So yeah, if my child is crying in the other room and I got to strap them to me during a telehealth visit, I'm not going to feel embarrassed about that. I'm going to tell my patient, hey, I'm a mom. I strap a baby to me sometimes during a telehealth visit to keep my baby calm, but I'm here for you, and this is what I can do to be a good overall person. And I understand that we all have things that we're going through and we're never going to be totally perfect.
No, that's a great point. And Harjot, someone that's been pretty much full-time telehealth for many years now too. What's your perspective?
Well, I looked into the issue and I found something which is in a new team, the providing team is still more once all in the same place at this point. However, because we have been doing it for a while, our providing team is also spread out. So our doctors are all over the country. And our people who are coordinating from our side are also not at the same place. So then we have to look into how remote teams work. Tell them the team or not, Because even if we see the patient, sometimes I may not see my coordinator, who is, in the background running everything, making sure the scut work doesn't come to me. And
Right.
that's where some of the sinister things start to show up in remote teams. So Vital Smarts, they had done research. They showed that when they studied, when they actually studied it, that 13 out of 14 common workplace relationship problems, they happen 2.5 times more in virtual teams, in relationship and communication. And what people have found is also that when you try to solve these problems, they also are more difficult to solve, and they also take longer to solve than on-site colleagues. Because it's natural next step that the team is gonna go remote when that starts to happen. At the same time, the problems are not just actively done. There is a lot of passively bad things that start to happen. Silence, dissuading people from working with remote colleagues, criticizing, gossiping, and because it's hard to read body language, misreading body language at times in remote teams, it happens 2.5 times more common than the teams that are at one site. At the same time, if you think about it, now we don't notice it as much, but this becomes so prominent in remote teams. This was an article in Harvard Business Review that almost a third of value-added collaboration in any team is going to come from about 3 to 5% of the employees. These are highly engaged people in a particular team who are on the opposite end of the burnout. And in a remote team, just imagine a discussion is happening. They are going to be looking like they're live wires of energy, and the ones who are not contributing, they're going to stand out. And their contribution or lack of contribution, the downward shift in productivity on that end, and the low bar that they are going to set is very clear to see. And that is not a very good place for creating burnout. If you look about, as I had mentioned earlier, it puts even more pressure on the team leader to have even more two-dimensional communication, and which is texting instead of talking. And there's less chance of socialization before the meeting, after the meeting. So actually, the remote work can put a lot of pressure on the teams in that way. So for a doctor, to feel efficacious is to feel spiritual. My life is meaningful, my work is meaningful, my life and work have a purpose. All three can kind of deteriorate in remote teams if it's not taken care of. I'm going to put a shameless plug here. Healthcare Administration Press is coming out with a book called Physician Engagement: What it is, why you need it, and where to begin. Because engagement is the opposite of burnout. And my chapter is the showcase chapter in the book. The book excerpt, you can go and read it. That's where what I basically talk about is that doctor needs to feel like they're engaged.
On that note, we're running out of time, so this is our last question. Okay. But I want you to finish your thought on that note. And this is the question, because it's how can we work to improve quality, right? Because that's exactly what you're trying to answer there.
Yes.
Quality and access to telehealth, so it becomes a more universal part of the healthcare ecosystem. Let's end with this question. Let's tie it all together, because really that's what we're looking to do. Yep. We know telehealth as a tool is going to become mainstay. It's just what we do as part of healthcare. What is going to increase its quality, its acceptance, its adoption, because it's here to stay? You want to finish your thought on Harjot?
Yeah, well, what I was going to say was that engagement, like everything else, can't be forced. We're going to engage. Right. You have to, the other person, human being, the doctor or the other workers have to feel like they're engaged in the work. And the concept is called flow.
Exactly. That's a great thought. So Chris, you want to have a
Yeah,
last-
again, like we talked earlier about the expansion of broadband and 5G networks, obviously, technology to become more easy and very simple, both from patients and physician standpoint. Having more training for physicians, both from a technology standpoint, a privacy perspective, as well as how to handle themselves when dealing with virtual type of care is important. And I think eventually the use of AI, where you could begin collecting data through telemedicine and do some predictions on what the provisional diagnosis is for a patient that could assist the physician before they even actually see that patient coming online, I think could be extremely beneficial. And in fact, you could use that data eventually, and with the proper algorithms, you could determine what's the appropriate visit for that patient. Is it a clinic visit? Can it do telemedicine? Can it be a phone call? Can it be asynchronous form of communication, the form of chat? All those are potentials. And that's where I think technology could play a better role in streamlining the type of patients that should do it, as well as assisting the physician in helping make a diagnosis in the management of the patient care. Not using AI exclusively, but as we get more data liquidity and more data is available to the patient who could then share with their doctors, and the use of AI, I think can certainly make life a lot easier for the physician.
Thank you, Chris. That's fantastic. So Brittany, as a summary before we close up.
Yeah, I would say I agree with a lot of what everybody is saying. You know, it's really important that we have access to data, that the patients have equal access to providers. So really making sure that underserved, not just remote communities, but also those in cities who don't normally have access to healthcare, have access in places where they go, like churches or barbershops or other community gathering places, where they can actually have access to good quality healthcare. So really improving that. And, you know, the last thing, it would be improving, you know, the health of teams, like Harjot was saying. You know, it isn't just the physician on these teams. We found that it was really important to train and hire the right people, not just to take a medical assistant from a clinic and stick them into a remote position, just like you can't take a physician from a clinic and stick them into a remote position without training. They need to understand how to communicate. The physician or who's ever managing those people needs to be well-versed in emotional intelligence, and they need to have regular meetings with their team and one-on-one meetings with their team, not just group meetings, so that they are checking in on the health of team members, because any person on that team who's going to be interacting with the patient is going to have an impact on that patient's health outcome. So I would say to our team in the hospital, you know, even the janitor working in the hospital had an impact on the patient's outcome from surgery. Every single person who touches any element of that patient's care, we need to make sure we're caring for those people as well, so that they're able to put their best self forward in patient care.
Thank you so much, everybody. I appreciate all of your time. We're going to open this up to the audience for questions and answers, and hopefully give them enough time. And on that note, I want to thank you again, Dr. Brittany Busse, Dr. Chris Pavlatos, and Dr. Harjot Singh, for your time today. It was wonderful discussing the future of telehealth. We'll see you guys.
Thank you.
Bye now.
Thank you.
Bye.
Welcome. So we're back to the live part of this with question and answer. Doug, thank you for moderating that. Harjot, thank you for participating. Thank you to Brittany. Thank you to Chris. I think this is yet another example of the value of having a place like Global Health Impact Network and a community focused around telemedicine and our Telemedicine 2.0 initiative to show the value of collaboration, okay? Because, you know, again, like we mentioned earlier, when you go to HIMSS and there's, you know, several hundred companies and everybody's at their own table and not talking to each other, not a lot gets done in terms of interoperability, where this is a perfect example of a group of telemedicine experts coming together to collaborate for the future of healthcare. So thank you, everybody. Good to see you all.
Good to see you, Gary.
So let me see. We've got. I laugh every time I jump on here because I'm sitting in front of 4 different streams. I've got a StreamYard stream for GHIN, and then I've got the YouTube stream for GHIN, and then I've also got the IMD group and their Zoom stream, which is actually streaming the YouTube stream. So we're all over the map. So there's questions and a number. Questions are coming from a number of different places. I'll start with for Harjot. We've been talking, the group has been talking about challenges in building remote teams. And certainly Global Health Impact Network and our Hands-In platform is working to address that from a clinician perspective. So when you talk about that, how do our clinician members in the audience build their remote teams to address these kind of issues, right? Not we can get as granular as the patient-provider interaction, but then there are steps above that as well at the practice level, at the enterprise level. So how do the people down in the trenches start to build those teams to take advantage of the technology?
Well, like I was talking about, there are 4 levels of factors that are going to come into play, no matter where and how we look at it. The first one are the legal factors, and then there are financial factors. There's no way around it. That's like the entry in. In fact, the finances are important. Brittany was talking about impact, but the money gets you in. That's what I've seen. If you can't kind of justify with money, but the money only gets you in. That's a very important thing to remember. It's true for jobs. It's true for hiring people, hiring employees. Now, the next step is technical factors. Just like you will not compromise on legal factors, you can't afford to compromise on financial factors. I would urge you, don't compromise on technical issues and factors. That's not where you're going to do any cost cutting. It's not going to serve anybody at all. That's right. That's where some time and money spent is going to go a long way to make sure things are done right. Even like, I may sound like I'm afraid because right in the beginning, we were always worried some bad thing was going to happen somewhere and we will be shut down. We're talking 2006, 2007. A lawsuit was going to happen in Ohio or somewhere. Somebody was going to do something weird and we were going to be shut down. No, none of that happened. But we still should not compromise on legal issues, financial issues, and technical issues. In fact, technical stuff is so cheap at this point. But the thing that ends up sustaining it, one of the commentators was saying that in innovator world, people want to build and sell and get out. Telemedicine is not like that at all. In fact, building it, okay, you're done, but then you're going to have to sustain it. And it's in ongoing sustenance where the impact is going to happen. The impact that everyone will feel for a long time to come. That's where the real innovation is going to happen. So that's where. So let's take what COVID has done. COVID has actually done. It's like a tree has been uprooted and shown the roots it's like a big storm has come and shown us for who we are. At the same time, this is a great opportunity. If you think from the crisis model, when a crisis comes, a team or an organization has 3 options. One is that it's going to deteriorate, disintegrate, disappear, and go away. Sadly, that does happen. The second is it'll try to come back to its baseline, and that's what the entire medicine is trying to do. And that is the wrong thing to do at this point. Mm-hmm. The third option during and after a crisis is to get to a new, better, higher, more efficient level of functioning. And that's where telemedicine is going to play a big, big role. Yeah. And like I was saying, this is where sometimes people start asking me, well, how do you train these telemedicine champions, or how do you create these teams? I said, look, each one has such an individualized situation. It is going to be like that for some time to come. So this is a very, very good opportunity to not only look at legal factors, financial factors, and technical factors, but also to put human factors in place, right, and not compromise on any of those things. I can vouch for it. In our experience, it was by not compromising that we sustained ourselves and serving the humans, like what Gary was talking about, team on this end and team on that end, and taking care of those people. Like our contracts, the sales cycle is long. We help them do paperwork, and they have political winds blowing on their end. So be in it to
Okay.
sustain and for the impact, like Brittany said.
Yeah. So, I mean, let's take this to the next level. As you all know, what's very important to me, having spent the last 9 years as an informaticist for a 27 hospital system and dealing with electronic healthcare records, short of having to avoid the darts that were thrown at those of us that were implementing it. Here we are now. We're post-pandemic. We have the advantages that the pandemic has given, but the expectations are also much greater as well. So to take telemedicine pre-pandemic, which was essentially a video connection between a provider and a patient, and then say, what we really need to build is to optimize the patient-provider interaction and make it more specialized, make it more targeted. I mean, there's no reason that a dermatologist and their patient should be using the same platform as a cardiac surgeon and their patient. So how do we take what we have, take it to the next level, and add that comprehensive interaction between a provider, including RPM, including CCM, including revenue cycle, including specialization of that interaction between the provider and the patient? Brittany, what are your thoughts on that?
So I think what we really want to do, and what Vitel is trying to do, is build those kinds of customizable solutions to find best-in-class EMRs that are already built, or to add in the features that each individual specialist is going to need. We started with occupational health, which was really different than general health EMR. You have to have a lot of specialized functions in there. You have to have a different way of communicating with patients and with different stakeholders that just simply weren't found in your traditional EMR environment. Mm-hmm. And we want to take that experience and customize that across the board. Like you said, we add in the ability to add RPM and CCM. We provide the right kind of clinical management. We can train the teams, using our connections, especially, through Harjot, because he's done that many times. And, we're really looking to create an online community with GHIN where we can find the providers, and we can bring these providers together, like we talked about during the talk, from all different walks and specializations in health, and create these customized solutions so that patients can come there knowing that they will be in control of their bodies, that we will find the best solutions for them, that we can knit together a comprehensive care plan for them, and we will become their guides to better health rather than the gods trying to control it.
Right. Doug, just quickly, some input.
So we've talked about precision medicine, and that's telemedicine is that tool that I believe, with interoperability and truly understanding the ecosystem, and the ecosystem is all about people, right? It's about the physicians, it's about the patients or the workers, and the payers are all part of this ecosystem. So as long as we understand what each stakeholder requires in that ecosystem, and we streamline it, and we meet those expectations of that ecosystem, it becomes a much more personable, and it can be a much more personable, real relationship where it solves not only this physician burnout, which is a big topic. Real relationship where it solves not only this, but it also is a part of a bigger solution, which is solving the interrelationships between all parties And that can all be done with the technology we have today. We didn't have this before, Gary.
Yeah.
And me being a technologist for my entire life and seeing where we are today and the tools that are available through AI, telemedicine is another tool that we use. The remote patient monitoring, chronic management, they're all combined to provide a preventive way to better medicine.
Okay, great. I'm just trying to keep track of the time.
Yes.
Nicholas just gave us a little bit of a reprieve. I apologize.
It's 4 o'clock.
Chris had a little bit of a trouble getting in one of the 4 streams that we
Hey,
have.
Chris.
Hey, how are you, everyone?
So here he is. Welcome.
Sorry about that.
It's great to have you here. So from a patient MD perspective, just take maybe about 30 seconds to talk about how you're working on, adding a level of specialization and optimization for that patient-provider connection.
Yeah, I think what's really critical for us, and something that you believe, as I do believe, Gary, we need a network. We need a network of physicians and a community of physicians, and we need various technology that will allow us to be able to deliver the best quality of care to our patient. That requires multiple technology fully integrated on a single platform. And that's been one of our focuses with Patient MD. Create a one-stop shop for the digital health world. So physicians can go to one place, patients can go to one place and connect with doctors across different areas in their community or across the country. And I think that's what's really important. That's what people are looking for. I think physicians are looking for that, patients are looking for that, and that will take the technology headaches out of most physicians' practices, where they can go to one facility, one place, and be able to get all the services that they need fully integrated, and we're connected with each other. That's absolutely critical for us as physicians, to stay connected with each other, communicate with each other, share information with each other regarding patient care. And I think that's going to be the future of medicine and the future of our profession.
Great, thank you. So I think that, what resonates amongst the whole group and probably this whole day is if you look at the bottom of the screen and you see GHIN, you see Innovator MD, you see Summit. What do those emanate, or what comes to mind when you look at that? Well, the market differentiator of what we're all creating here is this is a clinician funded, founded, and driven environment, okay? It's the clinicians taking back healthcare and returning ourselves to the clinicians, guardians of healthcare. And the only people that can do it are the clinicians, really. Of course, we need the help of the employers, and we need the insurers, and we need all of that. But at the end of the day, we're the ones who have to drive this. And that's what we're creating with Global Health Impact Network. And I have to tell you, I'm honored to have individuals like Chris and Doug and Brittany and Harjot working with us as part of this network, building this. And at the end of the day, the message to all of you listening to this is that as clinicians, you need to be part of this. You need to actively get engaged. You need to join the network, join the communities, get involved. We're democratizing the investment process through the fund, but it's a small part of it. But we want you to be advisors, consultants, active participants in our future, because without it, we're going to end up with EHR 2.0. And I don't think anyone wants to go in that direction moving forward. And then the other thing that we are working on, we haven't forgotten about the patients. This group is actively looking at working on building the patient side of this network to connect those clinicians to the patients, not just in episodic care, but in complete care, involving preventative, involving episodic, involving chronic care management, and just in general, how do employers take care of the employees that work for them and provide them with the resources, both technologically and face-to-face in a hybrid model, to improve the healthcare delivery system moving forward. So again, I thank all of you. We're about 3 minutes over. I would encourage everyone listening to jump on the network. You'll have access to all of these incredible knowledge leaders that have been, on a lot of our talks today, and get involved. So thank you, everyone.